The topic is biometry and IOL power calculation. This is very important for our daily practice. So you should watch very carefully what Dr. Anup says.
Good afternoon. Good afternoon. Actually, biometry generally is a topic which many of us ophthalmologists, we really don't like it, because many of us have become doctors to avoid mathematics and physics, and this is full of that. So, but unfortunately, we need to know this, because a lot of our results, post-operative cataract results, would depend on this. Unfortunately, many of the times it is the optometrist to do it, but still we need to know something to guide them. So factors which affect IL power calculation, these are the various factors: keratometry, axial length measurement, these are the most important. Then the velocity that you will choose on ultrasound, effective lens position, that is something of is very highly important, and of course your surgical technique. Coming to the biometry part, A-scan biometry, which is used to it uses high frequency ultrasound to estimate the distance between the ocular structures. And it is important, accuracy is important, because even a 0.3 millimeter defect in the axial length can lead to a one diopter error in IOL power. So the methods of doing A-scan biometry: handheld, or also called as contact; stand-held, or applanation. Just like you do an applanation, you fix it on the stand. And the most important and the most accurate is the immersion. Coming to the procedure, it is important that your procedure should be good. One is the safety of the patient. So you have to sterilize the tip before each and every patient. And then here I am demonstrating the immersion one. So you have to sterilize the Prager shell. And it's always better to use 100 ml normal saline, which can be disposed at the end of the day. So you have to fix the probe into the Prager shell so that its lower tip comes up to the line, as you can see there. And then lightly screw it. You should not screw it very hard, you may damage the probe. And the patient has to lie supine, anesthetized. Again, this solution has to be changed every day. And then after keeping, you have to inject the normal saline so that it just covers, there's a line there for that also, it should cover the tip of the probe. And as soon as you do that, you press the foot pedal, you can see these various spikes. You have to take at least 8 to 10 measurements. That is important. And then after that, the procedure is over. You just remove it gently and put a drop of antibiotic. So that is the end of the procedure. So important things is, if you are doing contact, your probe should touch very gently on the cornea. And the alignment of the probe is important. It should be along the optical axis, or ideally along the visual axis. That is, it is possible when you are doing immersion, you can ask the patient to look at the fixation light. Corneal compression is the common problem with contact biometry, and it will give a falsely low reading. So this can be avoided by the immersion scan. Then coming to the reproducibility, that is an indicator of accuracy. So that is why we have to always take at least 8 to 10 scans. And if the difference between each of these scans is within 0.2 millimeters, that means that your scan would be fairly accurate. Optical biometry is the next generation of doing biometry. It is of course much more accurate, because here we use partial coherence laser and interferometry principle. But the thing is that it is costly, obviously. It is probably more than 10 times the cost of ultrasonic biometer. The advantage of optical methods, besides the accuracy, is that being non-contact, there will not be any cross-contamination, no risk of spreading conjunctivitis. And the ease of use and the speed of testing can be tested very fast. And it is especially useful in complicated cases like post-vitrectomy silicone-filled eyes, or those with posterior staphylomas when the posterior segment is irregular. The disadvantages is that even if you have optical biometer, you still need to have an ultrasonic biometer, because this laser doesn't penetrate opacities like corneal opacities or thick cataracts. So even if you spend a lot on the optical biometer, you still need to have an ultrasound biometer also. Because almost 15%, 8 to 17 on patient, you cannot measure with a optical biometer. You still need a immersion biometer. So what are the characteristics? So you have done the procedure and you see on the screen multiple waves. So how do you have to decide whether what you have done is right? One, what I said is, if you take 8 to 10 readings, the difference should be less than 0.2 between the readings. Anything which is outlier, like if you have a reading which is slightly more, then you have to discard that when taking the average. So the various echoes you can see here, the ultrasonic probe echo, then the corneal echo. The anterior lens echo should be more, 90% or more of the, if you take the corneal echo or the probe echo as 100%, this should be more than 90%. The posterior echo should be 75% or more. Then the retinal echo also should be 75% or more. So if these echo heights are less, that means your sound is going obliquely. And equally important is that the rise of the retinal echo, it should be 90 degrees to the baseline. So that is proof that your sound is hitting the retina perpendicularly. It is not hitting in an oblique manner. And seeing those orbital echoes, after the retina you have the sclera, and then the smaller ones are the orbital echoes. That is also important to see that, because if you don't see orbital echo, it is possible your scan is going to the optic nerve. So that means it is not through the visual axis. We have to avoid errors, some things that you have to do is you have to measure both eyes. That is always, even if one eye is pseudophakic, you have to still measure that eye, because comparison is very important. If the axial length difference is, if the axial length is less than 22 or more than 25, you have to repeat again. If the keratometry is less than 40, more than 47, you have to repeat. If the difference between the eyes is more than 0.3 millimeter, or if the IOL power calculated is more than 1, you have to repeat. So all these things in these conditions, you have to repeat, and ideally it has to be repeated by another examiner, not by the same person. And if there are issues, if you have any doubt, we have to go for a dynamic calibration. Already these machines have to be calibrated regularly, which the company people will come and do it for you. But dynamic calibration is where you have some volunteer from your clinic, one or two people. You just check their scan and just record it, like Mr. Santosh, it is 22 millimeter. And then whenever you feel a doubt, you again ask that person and check it. If it shows 21, that means there is something wrong in the machine. So that is a very good method of checking. Keratometry measures, again, there are different ways of doing it, the manual one as the automated one. And here also it is better if you have both, because one method will validate the other. So it always check the manual as well as the automated in all patients. So this is the procedure, sorry. This is the Bosch and Lomb model of a manual. You have to first calibrate it before each and every patient, or at least once a day. And the patient's chin and forehead should be rested properly, and the patient's face should be straight. Patient should not be tilting. And after you focus the Myers, you have to rotate this. There is a vertical knob, one is for the horizontal, and the concentric one is for the axis. So after doing all this, you will get this sort of a Myers, what you see, the examiner sees. And in here, the plus should in the center between here, it is horizontally, it is well aligned. There you get seeing only a single plus, but vertically it's still not aligned. Those two minuses should also come together. So on a normal eye, the anterior corneal radius is around 7.5 millimeters. And the posterior, which is estimated by most of the machines, it is 1.2 millimeter. And based on this, the corneal refractive index, which is used for measuring, is 1.3333. Then in special situations in aphakia, you have two lens spikes instead of one. In pseudophakia, you will have very high lens spikes with reduplication echoes. And pediatric cases, it is important, but most of the time you have to do under short GA. And here you have to again underestimate, you have to reduce the power what you are actually, because here your aim is to avoid amblyopia in that patient, at the same time aim for emmetropia in adult age. So that is the reason why we slightly undercorrected. So up to 2 years, the IL power can be 80% of what you have calculated, and between 2 to 8 years, rule of thumb is around 90%. Silicon filled eyes, that is again a problem. So here the velocity in, of sound in silicon is less. In 1000 centistokes, it is around 980. When ideally, you know that in vitreous and all, it is 1532. So here, because the silicon is dense, the sound is less. So it will overestimate the IB. If the axial length is 22, it may show it to be higher. So here the optical method is better. But in case you, and most of these machines, even the ultrasonic machines, there is a mode for silicon oil mode. So if you do that, it will correct for this, and they automatically do with the lower velocity, and you will get the reading properly. Or if you don't have that silicon oil fill mode, you can just use a rule of thumb, a correction factor of 0.71. If you multiply that, and the reading what you get can be used for the calculating the IOL power. But this is one thing, but even if your IOL axial length measurement is perfect, there is still a problem that the silicon oil itself acts as a negative lens. So even if your axial length measurement is perfect, you may still have around 3 to 5 diopter increase in the IOL power. So, but fortunately, most of these silicon oil is removed after 5 to 6 months. So the patient will have a high refractive error for 5 to 6 months. And after that, once the oil is removed, the patient will be emetropic. Post-refractive surgery again is a big challenge. I am not going into detail because of time, but the most accurate method they say is the clinical history method. But what is important is that anybody who is doing LASIK or refractive procedure should make it a point to write the preoperative K and the preoperative refraction in the discharge summary, because based on this we can calculate the IL power post-refractive surgery with a very simple mathematical calculation, that is K post-refractive surgery is equal to K pre-refractive surgery minus difference in spherical equivalent. Piggyback IOLs also, I am not touching on that. So the errors, most common errors which occur are in the prediction of the effective lens power. And again, various causes of error which occur is, like I said, because of compression of the cornea. And when the keratometry is performed after doing gonioscopy or tonometry, then the Myers will be distorted. And if the during surgery, if the IOL is tilted, all these things will lead to post-operative surprises. Coming to the next part of my talk, that is IOL calculation formulae. These are, we know the theoretical ones, the older ones. Then the regression, the classical one was the SRK2, and the combined, which is the SRK-T. So this is the standard formula. We all should know this, though we don't really use the regression now too much, but this is a very classical formula. The IOL power is equal to A constant minus 2.5 axial length minus 0.9 K. So this shows that any one point change in the axial length will cause 2.5 times 2.5 diopters of and the change in the refractive, and if one diopter change in the K will lead to 0.9. That is almost one diopter error in the IOL power calculation. So the axial length is most important. The A constant, though it is called a constant, ironically it is highly variable, because it depends on IOL dependent factors like the type and material of the IOL, the position, surgeon dependent factors like the technique of the incision, the placement of the incision, etc. So all these things have to be incorporated before calculating the A scan. The manufacturers gave the A scan based on the IOL type, but then we have to modify that. Then various generations, again the first generation, second, third, fourth, based on the various parameters that you use. The present one are the fourth generation. These are the newer formula, the Holiday 2, Haigis, Olsen, Barrett's Universal 2, Hill RBF and Kane. And many of them are available online. You can just directly go online and use them, and the results are definitely much more accurate. The newer formulas, you need to, in addition to axial length and keratometry, you need the lens thickness as well as the anterior chamber depth. So these parameters are also required. So SRKT generally can be used in the normalized 22 to 24.5 and more than 26 mm. Holiday 2 can be used for the whole spectrum from the short to the long eyes. Barrett's Universal 2 also can be used for the whole spectrum. Haigis also can be used for the whole spectrum. Hoffer Q generally preferred only for short eyes, less than 22 millimeters. So you have to know which formula to use in which eyes. You can just write it somewhere. This diagram is there. I just paste it somewhere whenever you do the biometry, so that you know that if the axial length is less than 22, you go for Hoffer Q. Then one other thing, IOL tolerance, this also is a factor. We automatically assume that if the manufacturer says that this IOL is 20 diopter, we assume it is 20 diopter, but it need not be. Ideally, there is a tolerance of plus or minus 0.25 is acceptable, but some manufacturers may have more also. A 20 diopter lens may actually be only 19.5, but that is beyond our control, and there is no regulation or something which we cannot force them to reveal to us the details. So these are the newer A-scan ones. I am not going to the depth of that. So thank you. Try to do some justice to this very vast topic in this 15 minutes.
Actually, it's a very good speech, and always think about that. Optometrist is not a IOL power calculation is not optometrist job. So doctors should know the biometry. Suppose the patient have an abnormal power, which is comes to you for the operation, you should check abnormal power when prescribed by the optometrist. Doctor should check, recheck, then you apply the power. Once the IOL is inserted, it's very difficult to do a refractive error correction, and lots of surgical required for the replacement of the foldable IOL. This is my advice to everybody. When there is an abnormal IOL power, check, recheck. Once it is inserted, there is a problem. Any question, anybody?
Just one more point I would like to add, that most of the formulae, they work well for the normal range of axial length between 22 and 25. So all the formula will give you the same measurement for the IOL power calculation. It's only for the extreme eyes, that is the short eyes and the long eyes, where you'll end up in having the post-op refractive surprises because of errors in IOL calculation. That is when you may have to repeat the measurements using different instruments, or use the latest formulae, the newer ones. That will give more accurate readings.
Now you also know the calculation of SRK1, SRK2. And this patient, doctor says that SRK2, it is when applicable for 21 to 24.5. But beyond that, below that formula, you have to apply SRK1. Less people applied SRK1 formula, that you must have to do calculation and also know the A constant of the power, the prescribed IOL. Then you calculate yourself, not depend upon the machine. That would be much better. And you do myopic little bit. What your suggestion?
Pardon?
Myopic.
Yeah, always better to.
Myopic
and depends on both eyes. If you are doing, then
when you do surgery, you do little bit myopic. One diopter, that will be better tolerable. Hypermetropy is not good tolerable for the patient. I'm correct?
Yeah, definitely. Like one eye emetropia and the other eye non-dominant eye, or a 0.5 to 0.75 myopia if you make, then the patient can see distance as well as read. They'll be very happy actually.
I am myopia. I am reading without glass.